Hi, everyone. I'm so grateful that I have the opportunity to speak with you today about this critical topic, the myths and stigma surrounding POTS and the broader chronic illness community. While today's focus will be on POTS specifically, many of the insights and challenges I'll be discussing are relevant to other chronic conditions as well. I'd be more than happy to expand this presentation in the future to explore the myths and stigma associated with other illnesses seen in the chronic illness community. I wanted to take a quick moment to share a bit more about myself before we begin. So I started this organization in 2021, a few years after my health and life changed very suddenly. I am a chronic illness patient, and unfortunately, I've had terrifying experiences in many different healthcare settings. I've experienced profound loss, dismissal, and gaslighting, in part due to stigma and misinformation. If you've seen the A4P Instagram page that I've been running over the past few years, you've probably seen a strong focus on posts combating misinformation, and that's not by chance. I have seen firsthand the harm that misinformation and stigma can cause to patients, to families, to entire communities. So how do we stop it? Well, there are a lot of factors. So through education, through empowerment, through compassion, through understanding, and through many of the things that I'll be speaking about today. I was moved to start A4P not just because of my own lived experience, but also because of someone very special, Amelia Moore, the daughter of a close friend and one of the co-founders of Dysautonomia International. Amelia passed away in 2016 after a fierce battle with multiple chronic illnesses. The dismissal, gaslighting, and neglect she experienced were devastating. And yet the way she showed up for others with love, advocacy, and unwavering care left a permanent impact on so many, myself included, as her mom has shared so many parts of Amelia with me. Her legacy is a reminder of why this work matters and why we must keep fighting for change. Here is a breakdown of all the topics that I'm planning to cover today. I had to cut a lot out in the interest of time, but I still hope that there's enough here to have an impact. So why are we talking about this? Here are just a few reasons why, based on a few different studies. When reviewing the results of a long-term POTS outcome survey that included 227 participants seen in a study published in 2024, over 50% of patients were told their illness was in their head. Even when working with individuals struggling with psychiatric illnesses, which is my area of expertise, you never dismiss someone by saying that, ever. It's unprofessional and unethical. And POTS is not a psychiatric illness, which makes it even worse. The same study found that 65% of patients were told they had a psychiatric condition prior to a POTS diagnosis. And after diagnosis, they discovered that only 1/3 actually had a co-occurring mental health concern. And it's hard to say how much their dismissal and trauma when seeking a diagnosis with a debilitating condition contribute to the eventual co-occurring mental health challenge, understandably. Though the length of diagnostic delays has been improving, at one point it was close to 5 years. The average diagnostic delay is still 24 months, 2 years. And that includes challenges with being misdiagnosed. As if this wasn't already unacceptable, for those 2 years they are undiagnosed, are they able to work? 25% of those with POTS experience such severe symptoms they can't work or go to school. For those 2 years, how are they labeled? How are they treated? We already know that those with POTS have a poor health-related quality of life. So what about before treatment? And then what about when they're finally diagnosed? Is salt the only option given? Is support provided? We do know from a study published in 2017 that the POTS community is at high risk for suicide. I can't reinforce enough how concerning this is and how important this topic is. Some have been told by providers that having a POTS diagnosis in their chart will hurt them. Why? We have an opportunity to improve outcomes and quality of life by combating stigma and increasing support. Let's review some of the history. So dismissal and misdiagnosis is not unique to POTS. It has been seen in many other conditions, particularly autoimmune like lupus, vasculitis, and rheumatoid arthritis, just as a few examples. These conditions impact all genders, but they are more common in individuals assigned a female gender at birth. There is also gender bias in medicine. It has been studied and it impacts health outcomes. There are autoimmune disease health disparities, and there is studied and understood long-term harm from dismissal and attributing symptoms to psychological causes when that is not what an individual is experiencing. We've seen that historically, providers tend to lean towards using psychosomatic models when individuals present with illnesses that lack objective measurements, like a biomarker that can be seen in blood work. This is seen in individuals with POTS despite there being an objective measurement when using a tilt table test, other autonomic testing, and even the poor man's tilt table test. Unfortunately, this is also seen in individuals living with very disabling conditions such as ME/CFS, which Dr. Eddy is going to be talking more about later today. It's not uncommon for individuals with POTS to also have ME/CFS as a co-occurring condition. We also see this challenge with MCAS and EDS and many other conditions you will hear us discuss during the conference, and the acronyms will be broken down as well. I hope that these few slides have reinforced how serious this is and why I'm going to be talking about this with all of you today. I hope for some of you who are listening, this is validating, that you feel seen, that you feel understood, and that you feel that this is a safe space for you. So before we talk about stigma, which is often more conscious, it's important to talk about implicit biases, which are often unconscious and stem from our upbringing and environment, factors outside of our control. So unequal treatment may be a consequence, and you likely don't realize it, and awareness and training can make a difference. I have to stress that all of us, myself included, have implicit biases, all humans, but how we understand them, respond to them, and work on them is what varies. So if we're in denial and believe we don't have any implicit biases, that is where it becomes a slippery slope. What is good about implicit biases is that once we're aware of them, we can work on them to challenge these pre-existing beliefs and thought patterns. I highly recommend this Harvard implicit bias test for everyone, especially providers. You might be surprised by what you find, and it's okay. The desire to make a change and take those active steps and learn more about what your implicit biases are is what's important. Breaking free from what you've unconsciously digested. So now I'd like to talk more about stigma specifically. So what is it? It's an often conscious labeling that someone is different from you, but it definitely does not stop there. There are negative stereotypes that are involved. There's this idea of us versus them. And then there are often power dynamics and influence associated with stigma. There is some discrimination, though it has been debated if that should be a part of the definition by some researchers. There are different types of stigma. There's internalized stigma, and I like to think of that as a stigma we've eaten and consumed because of our surroundings, and it can impact how we view ourselves and the people around us, and even the world around us. There's social stigma, which is often present in larger social settings like workplaces and in academic settings. There's structural stigma, which can impact policy development and opportunities for individuals who are part of a stigmatized group, like those living with disabilities. There's associative stigma, where if one person is associated with someone else who is a part of the stigmatized group, like a spouse or family member, they too will have the stigma applied to them and be labeled. Then there is provider stigma, which involves healthcare providers stigmatizing different conditions, physical health conditions, and mental health conditions. This is a huge problem for those with mental health conditions, and it's also a problem for those with poorly understood and often dismissed physical health conditions like POTS. Stigma impacts the way we view ourselves, others, the world around us. It's a cognitive lens. It negatively impacts our vision and our decision making. Often we are aware of it, even if we experience shame and know that it's quote unquote wrong. Sometimes we're not fully aware of it, and we may not care if it's wrong. It can be subtle or it can be quite obvious. Here I listed some examples for the different types of stigma that I am going to go through with everyone today. So an example of internalized stigma is when an individual with POTS comes to believe they are less worthy of care, love, understanding, and support because they repeatedly heard this message from others who hold stigmatizing views, Over time, these external messages become part of their self-concept and how they view themselves, leading them to not only believe these things, but possibly also about others with POTS. An example of social stigma is when friends and family believe that individuals living with POTS are faking their illness because the symptoms are quote unquote invisible, which, by the way, if you look hard enough, the effects of POTS are very visible and very day to day. When they talk amongst themselves and reinforce this false belief, they strengthen the stigma within their social circle, making it harder for those with POTS to be believed or supported. An example of structural stigma is when employers systematically avoid hiring individuals with POTS because of pervasive stereotypes shared by others in their professional circles that label these individuals as either dramatic or anxious, as two examples. These biased hiring practices reflect institutionalized stigma that limits opportunities for people with chronic misunderstood conditions like POTS. An example of associative stigma is when the spouse of an individual with POTS begins to be excluded from family events, social outings, and gatherings because others now view them as anxious, difficult, or even attention seeking by association. Even though they do not have the condition themselves, they are stigmatized simply because of their close relationship with someone who does. Lastly, an example of provider stigma is when a healthcare provider assumes that a patient with POTS is exaggerating their symptoms and daily struggles, leading to dismissal of their concerns, inadequate care, or delayed diagnosis. This bias reflects the provider's misconceptions about the condition and contributes to a breakdown of trust in treatment quality. I would now like to review and break down 14 common POTS myths. 14 may seem like a lot, but there are so many that I wish I had time to unpack. Absolutely, we'll need to unpack them in a future presentation. I often refer to this as putting a lid on POTS misinformation. So let's get started. Common POTS myth number 1. Everyone living with POTS needs the same large amount of sodium each day. So what works for one person may be too little or too much for someone else. Not to mention that other co-occurring conditions need to be considered, and the type of POTS might influence this in one or more ways. We need to consider electrolyte abnormalities, and there are safety concerns in making this sweeping generalization for everyone living with this condition. Yes, it's true that research has demonstrated that a high sodium diet combined with increased water intake is often recommended and can increase blood volume, improving symptoms for many, but understandably specific amounts and what works best for each person varies. Some in our community can't drink large amounts of water or can't drink any water and are dependent on other forms of hydration as an example of the variability. So we really need to shift away from the generalizations for everyone living with this syndrome, which often varies from person to person. Common POTS myth number 2. Everyone living with POTS faints. Everyone living with POTS does not faint. I've had people tell me that they've struggled to get diagnosed because their provider has said that since they don't faint, they don't have POTS. Some living with POTS do struggle with fainting, and it can be debilitating, but it is not the most common symptom. It's not required for diagnosis, and actually near fainting, which we also refer to as pre-syncope, is much more common in the POTS community. Common POTS myth number 3. A POTS diagnosis requires the blood pressure to drop upon standing. This is a common one and does lead to a lot of diagnostic delays. It actually contributed to my diagnostic delay. I still remember when I was in the hospital early in my POTS journey, and one of the physicians checked my orthostatic vital signs, stated that I didn't have POTS because my blood pressure did not drop when I stood up. This was at a very prestigious and well-known hospital. So it's important to note that a POTS diagnosis requires the absence of orthostatic hypotension, which is a drop in systolic blood pressure, which is the top number in your blood pressure reading when standing by more than 20 millimeters of mercury. All right, common POTS myth number 4. POTS only impacts your heart rate. This is a common misconception, but it's far from reality. So POTS is a form of autonomic dysfunction, also known as dysautonomia, meaning it affects the autonomic nervous system. This is the part of the body that's responsible for all of the automatic functions we don't normally have to think about. When the autonomic nervous system is not functioning properly, seen in POTS and other forms of dysautonomia, it doesn't just affect the heart rate, it can cause dysfunction in multiple systems throughout the body, leading to a wide and complex range of symptoms. These can include tachycardia, palpitations, chest pain, nausea, diarrhea, bloating, brain fog, headaches, dizziness, urinary urgency or retention, heat intolerance, cold intolerance, and sweating abnormalities, insomnia, disrupted sleep cycles, severe fatigue, exercise intolerance, sexual dysfunction, and many other symptoms that Dr. Reddy already discussed with you today. Because the symptoms are widespread and can change from day to day, many people, sometimes even healthcare professionals, mistakenly believe they are exaggerated or dramatized, but this misunderstanding stems from a lack of awareness about how central the autonomic nervous system is to our body's basic functioning. When you understand what the autonomic nervous system controls, you begin to understand the chaos that can unfold when it stops working properly. POTS is not just a fast heart rate, it is a multi-system condition that deeply affects quality of life and daily functioning. Common POTS myth number 5, POTS is rare. POTS is often misunderstood, not rare. It wasn't rare before the COVID-19 pandemic, and it is definitely not rare now. Researchers have reported seeing a 5-fold increase in POTS cases since the start of the pandemic. It is often seen in individuals with long COVID, but there are other triggers and causes as well. It is not rare. Common POTS myth number 6, POTS is caused by anxiety. POTS is definitely not caused by anxiety. As someone who finished her training as a psychiatric mental health nurse practitioner, I believe in the importance of ensuring that those with anxiety disorders, which can be debilitating, have access to the supportive care that they need. The challenge with this myth is how pervasive and harmful it is. The myth that POTS is caused by anxiety not only leads to increased diagnostic delays, but it also reduces access to the treatments that would make a sizable difference. It's also critical to note that because of this myth, when individuals who do have POTS and other poorly understood chronic conditions understandably experience anxiety because of their symptoms or how they're treated in different environments or what they're experiencing, they can fear speaking up, and then they may not have access to the mental health support that they need. When you're living with a debilitating chronic condition, there are many layers and needs. This myth can block access to what is needed. I can't stress enough how dangerous this is for the community, not just for those with POTS. I'm talking about everyone living with poorly understood chronic conditions that are misdiagnosed when providers don't have the answer. The best thing you can do is say you don't know. The worst thing you can do is pretend to know and then give someone a diagnosis that is inaccurate and will follow them in their chart. POTS is a cardiac condition. Common POTS myth number 7. As I've already shared, POTS is a form of dysautonomia, which refers to the malfunctioning of the autonomic nervous system. Individuals with POTS do experience cardiac symptoms that can be extremely challenging, but POTS itself is not a cardiac condition. It is a neurological condition. Common POTS myth number 8. Most people will outgrow POTS. I've seen on social media individuals saying things like, there's a cure for POTS, or you'll only have POTS for a little bit. Mine has gone away, and yours will go away too. Longitudinal study demonstrated that once you develop POTS, most don't outgrow the condition. Some absolutely may find that their POTS goes into remission and their symptoms significantly improve, but that's very different from it simply going away. There are medication and non-medication options that can help increase quality of life, daily functioning, and hopefully lead some towards remission. But simply telling people something along the lines of, oh, if you don't think about it, it will go away. Or, oh, once they're a little older, it will just disappear. It just isn't true. Common POTS myth number 9. POTS only impacts individuals with a female gender assigned at birth. Although this is the case for a number of individuals with POTS, and POTS does disproportionately impact those who are younger and assigned a female gender at birth, there are absolutely many other individuals who can develop POTS, and we need to be mindful of this. We don't want to make the mistake of labeling POTS as an illness that only impacts a certain group and then have that misinformation contribute to diagnostic delays and dismissal for those who aren't in that group of individuals. Sure, there may be certain patterns we need to be aware of, and it may be much more common in certain individuals. Yes, it's more common in individuals who are younger and more common in individuals who've been assigned a female gender at birth, but we need to move away from these sweeping generalizations that are not accurate. We don't want to take 3 steps forward and then 5 steps back. Common POTS myth number 10. POTS treatment is the same for everyone. This is just not true. I think it's easy to throw water and salt at individuals with POTS and hope things get better, but POTS treatment is just not the same for everyone. Yes, we do need to focus on hydration and sodium to increase blood volume, but what about occupational therapy, physical therapy, compression garments, other co-occurring conditions that also need to be considered and managed and may be contributing to their POTS? What about their symptom severity? Would they benefit from mobility aids? Do they need accommodations in academic settings? What about for employment? Do they need IV fluids? And do not tell me that IV fluids can't help individuals with POTS. The research suggests otherwise for some in the community, especially if the IV fluids allow for symptom relief that can improve functioning and engagement in physical therapy. And let's consider quality of life too. Do they need a port? Do they need nutritional assistance? There is just so much more to POTS than a stamp that everyone gets. It's a syndrome. It impacts people differently. Yes, there are absolutely similarities, but we are continuing to learn more about the many differences. So understanding POTS in that way and the need for individualized care and treatment is key. Common POTS myth number 11. POTS treatment doesn't require prescribed medications. This is a common myth. Many living with POTS need access to medications like beta blockers, ivabradine, also known as Corlinor, midodrine, and/or fludrocortisone, just as a few examples. There are certainly more that Dr. Azzola will be discussing later today. These medications are often needed in combination with non-pharmacological treatments for symptom relief. Common POTS myth number 12. I could do this all day long. POTS is a new fad that people want. That's why more people are being diagnosed. POTS is a debilitating condition with a quality of life similar to those with congestive heart failure. No one wants to have POTS. I have yet to meet anyone who has wanted to have POTS. What people do want are answers that lead to access to supportive treatments for their symptoms that can increase their quality of life. When individuals in the community are suffering and they're being told that nothing is wrong, when in fact through their research and reading, they realize they may have POTS, there is relief when they are diagnosed because they hope this means that this is the next step towards access to what they need for symptom improvement, increased quality of life, increasing functioning, and for some, their ability to go back to school or go back to work or shower on their own or sit up in bed or focus long enough to read part of a book or watch part of a show or have a call with a friend. You name it. Common POTS myth number 13. Once you're diagnosed with POTS, you have all of the answers you need. For many, POTS is a piece of the puzzle, not for everyone, but many. It is common for individuals living with POTS to have other co-occurring conditions, and they can contribute to POTS symptoms if they aren't appropriately managed, or even when they're appropriately managed. As an example, my POTS is triggered by my MCAS, and when my MCAS gets worse, my POTS gets worse. When my MCAS gets better, my POTS gets better. So mast cell stabilizers have helped me with my POTS. That doesn't mean that I don't need compression garments and salt tablets and that I haven't needed a beta blocker, etc. But it is one example of a case where POTS was the first answer, not the last. Being mindful of this as a possibility is important, leaving no stone unturned. Last but not least, common POTS myth number 14. Isn't this fun, putting a lid on misinformation? So essential. Mobility aids aren't helpful or necessary for those with POTS. No, no, no. The use of mobility aids such as wheelchairs, rollators, shower chairs, scooters, etc. can allow for increased autonomy, safety, functioning, and quality of life. And it is not you either need them every day or not at all. Some may need them daily, some may need them weekly, some may need them occasionally, some may need them during flare-ups, some may need certain ones during flare-ups, or randomly. It varies. So if you see someone with POTS or another co-occurring condition or chronic illness using a wheelchair on Monday and they aren't using the wheelchair on Thursday, it's not because they didn't need the wheelchair on Monday. It's because the symptom severity fluctuates, and that can be the nature of these very challenging conditions and this very challenging form of dysautonomia. And know if people use mobility aids, they are not weak. They are courageous for listening to their body and doing what is best for them, despite the stigma around them and despite the judgment from others. I love when mobility aids are used. They can open up so many doors for individuals with POTS and other co-occurring conditions. All right, I wish I had time to unpack more, but I'm limited on time today. So let's review this POTS stigma cycle that applies to other chronic conditions too, which I developed a few years ago. This is a general cycle, but here we are starting with discrimination and stigma, which can then lead to dismissal, which can then lead individuals to fear reaching out for help, which can then lead to grief, which can then lead to avoidance of medical appointments, treatments, friends, family, you name it, which then can increase risk for isolation. And then all of this combined and avoiding medical appointments and treatments can lead to worsening symptoms. Then they may reach a point where symptoms are so much worse they don't have a choice and end up in the ER, and then the cycle can happen all over again. One of my many goals through this advocacy and awareness work is that the cycle breaks, not just for those with POTS, but for those experiencing symptoms and living with conditions that aren't well understood. I think I've touched on this already, but stigma and myths are pervasive, harmful, and impactful. They can contribute to diagnostic delays, dismissal, and quality of life challenges. There's absolutely a role of stigma and gender bias, and unfortunately, all of this can eventually and quickly lead to an erosion of supports and supportive options. There can be increased isolation and fear of speaking up and seeking help, and even provider stigma may impact internalized stigma. So one of the questions that I have is, to what extent are health outcomes impacted? How is the dismissal and stigmatization increasing suffering and risk for suicide? I don't have an answer. My guess is that it's playing a larger role than we may realize, and part of my dedication to the community involves changing this however I possibly can. So what else needs to change? Well, we need to have dedicated provider trainings and education, and I am not just referring to ensuring that they know how to diagnose POTS and what the needed treatments are and diagnostic criteria, etc. I am talking about the deep-rooted issues that this kind of education will not fix. I am talking about trainings and education that targets the POTS stigma, POTS myths, implicit bias training. And yes, this is something that I can envision myself in our organization doing. Combating stigma requires a multifaceted approach. We have seen that education is not enough. There's a role for sharing experiences, advancing policy changes and reform, creating and fostering non-judgmental environments. And of course, the advocacy and education is needed. Diagnostic delays are improving, but I still see a mountain of work ahead of us. And as daunting as that may seem, there is a path forward. It may be slippery, it may be arduous, but it's there. Lastly, I wanted to share these important reminders with you as we near the end of this presentation. Living with a heavily stigmatized condition is painful. There is no sugarcoating that. It makes sense why you may be physically and emotionally completely drained, why having hope on some days may feel impossible. And I'm here to tell you that it is okay to not be okay. On the days when you don't have hope or you can't find hope, or it doesn't mean that there won't be hope tomorrow. It's important to engage with people who are supportive. And I know this is a lot easier said than done, but it's important. Advocates do care and change is happening, even when it doesn't seem like it. You're going to hear from many more wonderful advocates and providers over the next 2 days who I hope help you feel seen, heard, and understood. Please do not forget and always hold on to the truth that your voice matters and your story can make a huge difference. It may seem like everything around you is dark, but maybe you are the one with the lantern guiding others around you. These are all of my references. All right, I hope that there was at least one takeaway from this presentation that makes a difference for you or someone that you love, someone that you care about. I will be at the Q&A later in the day. If you have questions, you can submit them here. You can email me. I look forward to sharing more information with all of you tomorrow, as I will be talking about POTS self-advocacy and navigating flare-ups, two more topics that are very near and dear to me, and I'm looking forward to sharing that with all of you. Thank you for your time.